For joining us for this presentation. At least this Zoom has helped us reach multiple countries. So please do share where it is that you're joining us from for us to at least recognize you. We are encouraging people to join the doctors, to join, and students as well, to join the association, Kenya Association of Pediatric Dentists. Is at a cost of 5,000 shillings for the doctors and 4,000 shillings for the students. The benefits, of course, such webinars, CPD webinars, which is free, of course, but then when face-to-face trainings and resume, we will definitely give you preferential pricing. We also will be awarding points for everyone. It doesn't matter whether you're a member or not. And then there's also good packages where we have the website. You can get previously done webinars. You can watch them at any time. However, those ones will not have points allocated to them. I want to welcome you all. Thank you for joining. There's Said Neymar. Hi and welcome as well. You didn't say where you're from, at least for us to recognize you. I'll quickly introduce Dr. Scott Omutimba as we set to start at 5 past. We have about 95 attendees, so I think we can do the introduction. Dr. Scott Omutimba is a BDS graduate from the University of Nairobi. He's also done his master's in public health at the University of Moi University. He's done his orthodontics, MSD orthodontics in the Suez Canal University in Egypt. He's a lecturer in the Department of Paediatric Dentistry and Orthodontics in the School of Dentistry in Moi University. He's also, that is in Eldoret, he's also the orthodontist, consultant orthodontist at the Moi Teaching and Referral Hospital in Eldoret, and a member of this Kenya Association of Kenya Dental Association, as well as the International Association of Pediatric Dentists. So please remember that you should ask all your questions in the question and answer section of the webinar, not in the chat box, and we will answer all questions at the end of the presentation. So without further ado, let me welcome Dr. Scott Omutimba to do the presentation. I hope you all enjoy and benefit from this particular presentation that Dr. has set for us. And this will be on the management of crowding in mixed dentition. Welcome, Dr. Scott.
Thank you very much, Dr. Mutai, and the Kenya Association of Pediatric Dentistry for honoring me with this opportunity to just share and learn with one another. Indeed, it's a privilege to be part of your association, and also it's a pleasure also being in the International Association of Pediatric Dentists. I think it is one of the most cozy professional associations I've been able to be a part of, and I've enjoyed the interaction that I've had with them, especially last year when we had the triennial conference in Nairobi. It was a really wonderful time, and I think they have a way in which they treat you like a baby. They have a lot of TLC, so I really have enjoyed for the time I've been a member of IAPD and KAPD, and I look forward to more interaction. So thank you so much for honoring me just to be able to share this presentation today. So my discussion, I'm going to talk about how to manage crowding in the mixed dentition. Crowding being one of the problems that we have to handle in the mixed dentition. I know as a pediatric dentist, most of the patients you treat in this dentition. So it is a very important area that you would want to have some insight. So just briefly, my outline will follow that. So basically, I will start by talking about this mixed dentition. It's just it's the stage of tooth development where we have both dentitions in existence. That is, the deciduous and the permanent teeth are present at the same time. And we could roughly say it starts with once the first permanent tooth has erupted and ends once the last deciduous tooth has been shed. And some people will talk about it ranging, starting from 6 years to 12 years. But I think there's a lot of ratio variation in the eruption ages. So we cannot really strictly say that it's from between 6 to 12. That is just a guide. For example, like today is a month since my 6-year-old daughter turned 6, and she already has first molars. I mean, it was a bit of a surprise. So there is a variation among the different populations of this stage of development, but still almost close to one another. So I want to just begin by classifying the mixed dentition problems. Broadly, we could classify them into skeletal and non-skeletal problems. And among the skeletal problems, we talk about class 2 and class 3 problems and crossbites. And then the non-skeletal problems, which are the focus of our discussion today, we have the intra-arch, that is problems within the arch, and inter-arch, meaning problems between the two arches that are concentrated between the two arches. So among the intra-arch problems, we could further classify them into space problems and eruption problems. And the inter-arch problems could be classified into vertical problems, occlusal and transverse problems. So narrowing down now to the space problems, we can have problem of excess space, or problems of premature loss of the teeth with adequate space. In such a scenario, we aim at doing space maintenance. We could also have what we call localized space loss, where the space loss is 3 millimeters or less. And in this instance, we want to aim at regaining the space that has been lost. Now, another space problem is mild to moderate crowding of the incisors with adequate space, and moderate and severe generalized crowding. So these last two space problems are going to be the focus of my discussion today. So just in defining crowding, we could simply say it is a malalignment of the teeth due to deficiency in the space. That means that the teeth are not able to fit into the jaws adequately because maybe the teeth are too big, or in a normal jaw, or in in a small jaw and the teeth are normal. So there's a discrepancy in the size of the teeth as well as the size of the jaws. So because of that discrepancy, then you end up with the condition that we call crowding. And normally we can be able to make a clinical judgment just through observing by seeing the teeth are misaligned, or when we do some assessments through cast analysis, where we now just evaluate and do the calculation to actually see the discrepancy. So at the end of that, we are able to make a conclusion that there is indeed a diagnosis of crowding. So we could classify crowding in various ways. One way we could say it is either hereditary crowding. This meaning that it is something that has been inherited and is in the genetic makeup that tends to influence the size of the jaw and the size of the teeth. So when there is a discrepancy in this area, then you end up with the crowding. So it could either be hereditary or environmental. That is one way of classifying. Now, environmental are these acquired that come after the teeth have already developed conditions within the environment, the oral environment, that would cause now this crowding to come out. We could also talk about primary crowding, which again refers to the crowding that happens due to the inheritance. So one way it could either be hereditary or primary crowding. Secondary crowding, again, related to the environment. This is acquired to factors that may be in the local environment that may lead now to the crowding. And tertiary is now what we call late incisor crowding that happens much later during the development of the dentition. And then also we could also classify it as simple or complex depending on the severity. So simple would be much easier to manage and would not require so much, while complex is more difficult to manage and requires more extensive treatment. So these are the different ways we could also consider to classify the crowding. So just to talk about the etiology, the discrepancy that arises due to the difference in the size of the teeth and the difference in the arch length could also be considered to be the cause. And most of the time, this is inherited or genetically determined. The environmental causes or acquired causes, these ones include examples such as premature loss of deciduous teeth, which are lost before their time for shedding. So these causes may be drifting of posterior teeth and leading to crowding in the anterior segment. So for us to be able to make a good diagnosis, it's important once the patients present to us to take a good history and just do the clinical evaluation, be able to examine and be able to elucidate the problem that the patient is having. Most of the time, of course, the children that present to us will be brought by parents who would be concerned that the child's teeth are not growing properly, or they look like they are occupying too much space in a small area. So that will be able to be elicited from the history and clinical examination that you carry out once the patient presents to you. And most of the time also, this is usually the first orthodontic visit for the children that we see during this mixed dentition. So most of the time, a child may not get to see or to have an orthodontic evaluation until they develop crowding. So again, this crowding could be the reason why they would have now an orthodontic consult or orthodontic visit for the first time. So again, during this diagnosis, it's important to be able to have study models that are key in being able to evaluate and assess this problem. Of course, we cannot also rule out the need to have radiographic examination, mostly the panoramic and also intraoral periapicals. These are very helpful when it comes to assessing the degree of crowding or being able to determine the severity. So this is a very important step that we need to be familiar with, or to be able to make a good diagnosis and be able to come up with a definitive plan in being able to manage these cases. So usually the space analysis is done before we come up with a treatment plan. And basically our objective is to determine or to look at the difference between how much space is there and how much space is required. So when we do a comparison, we'll be able to decide whether the patient has excess space or a space deficiency. In this case, where we are discussing crowding, or definitely now we are talking about space deficiency. So the objective of doing the space analysis is just to be able to determine how much deficiency of space is there. Already if the patient has crowding, it is already telling us they have a space deficiency. So we would like to know what is the magnitude or what is the degree of this deficiency, and how is it going to guide our management of this problem. So it's very, very important that we familiarize ourselves with the different ways of doing the space analysis, and being able to come up with the correct or the values that will help us to be able to chart a way forward or come up with an appropriate treatment plan. So usually in this dentition, we would want to measure the space available on the study model. And usually we just do this by measuring from the mesial of the first molar to the mesial of the first molar on the opposite side. This is what this value will tell us how much the space the patient has, or what space is available. Now, once we know this, then now we will want to determine how much space does the patient actually require. And once we know the difference between the two, then we'll know the discrepancy that the patient has. And now from there, we can be able to determine the degree of crowding, and then now make a treatment plan or a definitive way forward based on that. So we have already said that the space available, we can obtain it from the study model by measuring from the mesial of the 6 on one side, the mesial of the 6 on the other side. But now we would also want to know how much space does this patient require, considering that they already are having a deficiency. So there are different techniques or ways of determining what space is required. Now, we know that this dentition is in a transition from the deciduous to the permanent dentition. And it may not be possible to measure the permanent teeth that are yet to erupt. So that is why these methods were developed to enable us to determine how much space is required for the permanent teeth that are going to erupt. And so these different techniques help us to measure the space that is required by the permanent teeth that are coming in. That is usually the canine, the first premolar, and the second premolar. So the first method, usually the radiographic method, is where you take a measurement of a tooth that is both present on the study model and one that can be viewed on the radiograph, usually a periapical film. Or if you have a digital panorama, you could still use it. And then you, using this equation or proportional relationship, you'll be able to compensate for the magnification and be able to use that value to determine the size, the expected size of the teeth that are supposed to erupt. So using those values and using these values of the teeth, the expected teeth that are expected to erupt, you compare with the available space which you have measured from the study model. So the difference between these two is what is going to be the discrepancy in this stage of development. Another way that you can use to determine the space required is the use of proportionality tables. Like the one shown in the slide is that developed by Moyer's prediction table. And it uses the size of the permanent incisors to predict the size of the unerupted canines and premolars. So by measuring the size of the permanent incisors from the model, you can be able to predict the size of the unerupted canines and premolars. The disadvantage of this proportionality table is that it is specific for the populations that it was developed from. So we may not apply it maybe in the setups that we are in, but just for our knowledge, it helps. Another prediction table is that by Tanaka and Johnson, whereby this one was for children from a European population, and it uses 1/2 of the mesiodistal width of the four. So you take the 4 lower incisors, okay, and divide by 2, and then add 10.5, and that will give you the estimated width of the mandibular canine and premolars in 1 quadrant, okay. And for the maxillary, you add plus 11 millimeters. So using these tables, you'll be able to calculate and arrive at the space required for the particular patient that you are seeing. And once you compare that with the space available, which you would have already measured from the study model, then you'll get the degree of discrepancy or amount of crowding in this case. This is another example of a prediction for a way for predicting the sum of the mandibular canine and premolars on one side. This is what is called the Wiley equation, which was developed in 1947, where x is equals to 9.41 plus 0.2525y, where x is the sum of the mandibular canine, the first and second premolar on one side, while y is the sum of the mandibular incisors, which you will obtain from the study model that you have taken from the patient. So again, with this, you'll be able to make your calculation for the required space of the patient. Most recently, Abul-Azm and Fowler equation, 1989, they used the bacolingual dimension of the first permanent molar, measure in the widest portion of that first permanent molar. So in this equation, the upper arch, for the upper arch, the mesiodistal width of the canine and premolars is equivalent to the bacolingual width of the first molar times 2 and take away 1. So that should give you the estimated size of the canine and premolars. in the upper arch, while in the lower arch, again, the mesiodistal width of the bacolingual width of the first molar times 2 should give you the estimated width of the canine and premolars. Now, for the mandibular arch only, you could also use the combined radiographic and the prediction method. What you see is what is called the Stalian Kerber graph that allows you to predict the canine width from the sum of the first and second premolars. So again, using this graph, you can be able to predict the width of the canine, and you add it to the width of the first and second premolars, and then that will allow you to determine your required space for this case. So once you have finished your space analysis using those different approaches, you will make the following inferences based on the findings. In situations where the discrepancy is equal to or less than 2 millimeters, it would be considered a mild or no discrepancy at all. While in between 3 to 4 millimeters, we would consider it as a mild discrepancy or just slight space loss. While if it's more than 4 millimeters, then that is moderate to severe discrepancy, which now requires different treatment modalities. So now I'm going to look at the management in the next segment, which is our focus for today's discussion. Now, I think the mixed dentition period is a transition period, and according to Gianelli, there is normally a lot of, there's some arch length loss during this transition from the deciduous to the permanent dentition. So it is usually good for us to manage this dentition well to minimize this arch length loss so that we can at least reduce the magnitude of crowding that will be present in the permanent dentition. So I think it's very important that we manage the crowding during the mixed dentition so that we can at least minimize or reduce the degree of crowding. Although some studies have said that the impact may not be so much in improving the crowding in the permanent dentition, especially if the deciduous dentition is very crowded. So I think we still have a responsibility as clinicians to manage this crowding and not wait until the permanent dentition to be able to manage it. So I think we will be able to have the skills and capability to be able to do this. So the mixed dentition, I would consider it like a road junction where many things happen. Most accidents actually happen during road junctions because of the changes that are happening there, people trying to move to this side and that side. So I think the same is true for the mixed dentition, where because of a lot of changes happening to the dentition during this period, we are likely to end up with more problems. So it is important that we try and manage the best way possible and as early as possible. So our goal mainly is we want to try and preserve the arch length and minimize its loss, and also to reduce the magnitude of the crowding in the permanent dentition. So in the mild crowding, where we have less than 2 millimeters of discrepancy, we could also consider it or call it transient or borderline crowding. And this could also be seen at about 8 to 9 years when the permanent inside, and usually it just appears like a mild facial-lingual displacement, or you have some rotation of individual anterior teeth. So when the patient comes to you, the crowding may not look so severe. And this is partly because of what we call incisor liability, whereby the differences in size of the deciduous incisors and permanent incisors. Because of the difference in size, we tend to have this crowding. But usually it resolves on its own because of maybe generalized and primate spacing that can help to correct this. And then, of course, increase in the intercanine, sorry, that's a typo. Increase in the intercanine width also will allow these incisors to align themselves and resolve the crowding. But there are scenarios where the parents might be very concerned and bothered about this. So if they insist, it is suggested maybe you could disc the B or C if the B is still there, to just gain some maybe 3 to 4 millimeters and allow the permanent incisors to align themselves. Especially if maybe the child didn't have any primate space or generalized spacing, then maybe this might be the option in correcting that. Now, in situations where we have mild to moderate crowding, which would be about 3 millimeters or less, if it's localized to the anterior region, again, you can just proceed without any treatment. But again, if the parents insist, then you might consider disking the C or the D, just to allow those lower anteriors to align themselves, as shown in the images below. If we have, in a case where we have mild to moderate crowding, again, which is about less than 3 millimeters and is localized to the posterior region, usually because of premature loss of the E, and you have drifting of the 6, then you can manage this by doing some space regaining. You can use on the extreme left is the gable space regainer. You can also use a split plate with a coil, a screw, jack screw, okay? Just
Apologies for that. We are trying to connect back. We should be back on in a few minutes. We should be back on any time now. Apologies. I think Dr. Omutimba lost connection for a second there, but we should be connecting in a few minutes. Kindly remember to post all your questions in the question and answer section, not in the chat box. We will end up losing the questions here when they're in the chat box. Kindly please post all of them. Thank you very much. Thank you for your question, Dr. Allen. We should answer it at the end of the session. And we are back. Welcome back, Dr. Scott Omutimba. Please carry on.
Sorry, I don't know what happened. It just went off. So is this where I'd stopped, or where did you lose me? Hello?
I'm saying I think you're in the section where you're talking about air rotor stripping and space regaining.
Here?
Yeah, about here. So you're
okay. Yes, so I was saying this is mild. We've made a diagnosis of mild to moderate which is localized to the posterior segment, is less than 3 millimeters discrepancy. So usually it's because of a premature loss of the E. So the best way you can correct this is by doing distalization. The 6, so you can use some of the appliances shown here, like this cable distalizer or the removable appliance here with the jack screw and a split acrylic plate. You can also use cantilever springs just on a removable appliance to be able to correct that. Now, in situations where you have moderate crowding of about 3 to 4 millimeters, which is localized anteriorly, this usually as a result of premature loss of the C. If there is no midline shift, then you can extract the opposite C and then put a lingual arch to prevent lingual tipping of the incisors. This is just to help also maintain the arch length. Now, in situations where you have moderate crowding of 3 to 4 millimeters with a midline shift, in this case, you may have to bond the incisors and use coil springs to correct the midline shift. So I think in this scenario, there was a C that was lost and the midline shifted to the right, the lower right. So the treatment was to bond the teeth that were there and using a coil spring to be able to correct the midline. So again, this is moderate crowding in the anterior region with a midline shift. In situations where you have moderate crowding in the anterior region, again of about 3 to 4 millimeters, and both canines have been lost, then you can do some expansion with an active lingual arch, like one shown in the image. And then now you maintain that with a passive lingual arch once the space has been corrected. In a certain scenario where you have again moderate crowding in the posterior segment, usually 3 to 4 millimeters, and in this scenario you may have either an impacted or an ectopically erupting molar. Usually you can extract the impacted tooth or the ectopic tooth, and then now you try and distalize to regain the space that has been lost using a lip bumper as shown in the diagram below. Now, for the crowding that I've been discussing is mostly localized, meaning it's either localized to the anterior region or localized to the posterior region. So the approaches are based when you determine this crowding in the localized to the posterior region or localized to the anterior region. Once you determine that, then you will be able to decide what approach to use to be able to correct. Now, when it comes to crowding that is generalized and is mild to moderate, you have the opportunity to do some expansion. For example, you can expand with what is called the Suez appliance in the image shown below, which is a removable appliance with a jack screw in the anterior midline, the lower jaw, and some ball clasps posteriorly for retention. Okay, it's usually activated once a week, and at the end of about 4 to 5 months, you would have gained close to 4 to 5 millimeters. So again, this is a good modality in trying to address crowding that is generalized and mild to moderate in severe degree. Now, the generalized moderate to severe crowding, this one usually presents with severe irregularity of the erupting permanent incisor. In fact, this one, when the patient presents to you, you can actually see that it's severe. And usually it presents with the early loss of the primary canines. And you have the option in this case of either doing expansion or extraction to be able to manage the crowding. So there is criteria that we usually advocate if you have to do expansion. Usually we would want, it's advisable that the patient has a normal or retrusive lower incisor position, then normal or retrusive lips. The patient should have adequate overbite. The overbite should not be too much. And also there should be good keratinized tissue facial to the lower incisors. Okay, so if you are considering expansion as an option, then it's good to be able to look at these parameters before you choose this as an option. So some of the expansion appliances that you can use are the quad helix, or the that's in the upper jaw, quad helix, and the bihelix in the lower jaw, as shown in the diagram. For the extraction treatment, again, we have the option of doing serial extraction, which is, as you know, is an interceptive part of the interceptive orthodontic procedures. Usually, we aim to correct tooth size and arch length, the discrepancies that have been inherited. This is a practice that began in Europe in the 1930s and has been advocated by many people, according to Kramer. So the indications for serial extraction, Usually there needs to be a deficiency of arch length in the tooth size. Patients should have class 1 malocclusion with good muscular and skeletal parameters. The overbite and overjet should be within minimal or acceptable values. And then where growth is not enough to be able to correct the discrepancy between tooth material and the basal bone. So if you evaluate the patient and see that the whatever growth they might have may not be able to correct it, then you can opt for serial extraction. So these are the contraindications for serial extraction, maybe class 2, class 3 with skeletal deficiencies, dentition that is spaced. Definitely you're going to worsen the spacing if you attempt serial extraction. Where there are absence of fewer teeth, again, we do not advocate that serial extraction would work. Open bite and deep bite are not good cases also. Midline diastema. If there's class 1 with minimal space deficiency, again, serial extraction is not a good option. Again, an erupted malformed teeth is dilacerations. When you have extensive caries or heavily filled past permanent molars. So again, when there is a small discrepancy, usually we don't consider doing serial extractions. So there are different methods for serial extraction. We have Dewell's technique, tube technique, and Nance technique. Usually, Dewell's is done in 3 steps. We begin by extracting the deciduous canines so that we can allow the incisors to align, usually at about the age of 8 to 9 years. Then a year later, about 9 to 10 years, we extract the first deciduous molars so that we can accelerate the eruption of the first premolars. So the modification, the premolar can be enucleated, especially in situations where we have the canine erupting before the first premolar. Dewell's technique, extraction, the first premolar, so that the permanent canine can erupt. In Treat's technique, is begin the extraction is the first deciduous molar at 8 years, then it will be followed by the first premolar and deciduous canines simultaneously. The Nance technique is similar, but it starts with the extraction of deciduous first molar, followed by first premolar and then the deciduous canines. So just to wind up, I say crowding is one of the commonest mixed dentition problems that we encounter as practitioners. And it's important that we be able to assess and be able to determine the degree of crowding so that we can know how best to manage it. And of course, it's good to be very familiar with the space analysis methods and techniques so that you can be able to assess and determine the degree or the magnitude of the problem. And let me not forget that early intervention is key. The earlier we see these patients and begin to manage the problem, the better it is for them. It helps for better success. So I think I will end my presentation there. Thank you for listening.
All right. Thank you, Dr. Scott, for the wonderful presentation that you've shared with us, and even the reminding that we have undergone during this time. Some of us haven't read about Tanaka and Johnson since campus days in undergraduate. So we will shift straight away to the Q&A. Kindly remember to ask your questions in the Q&A section and not the chat box so that we don't miss your questions. In the first question that is coming from Sony Kana, can you recommend a book or course to learn more about this subject? Dr. Scott.
Okay. You know, the interesting thing with orthodontics, the books are very, very many. And different things are in different books. It's really hard to really pick one book and say that this will give me what I want.
Okay.
I think for this topic, I think Profit is a good book. You know, Profit and Graeber. I think they do a good write-up on mixed dentition treatment generally.
Okay.
Graeber and Profit have very good chapters on how to manage the developing dentition, because basically this is about the developing dentition, how it's managed, especially orthodontically. So I think I have my email at the end here. So if someone really wants the specifics of the book, or they could just send me a note, and I would gladly share with them some of the books that I feel would cover this subject very well.
Okay, this should be the 5th edition of the book, I think.
Yes, yeah, the 5th edition, exactly, yes. I think for both is 5th, yeah, for Graeber and it's both 5th, yeah.
Okay, thank you. Same person is asking, are aligners used at this stage, the mixed dentition stage?
Are what?
Aligners, are aligners, yeah, at this mixed dentition stage?
At the moment, I don't think they would have much application currently. Yes.
Okay. All right. This is from Dr. Nelson Malenya. Thank you, Dr. Omutimba, for informative presentation. Please comment on the usefulness of fixed permanent appliances like twin force appliances, titanium appliances, and utility arch wires to go around compliance issues which are common with removables.
So he's asking, just see.
He's saying, please comment on the usefulness of fixed appliances like twin force appliances, titanium appliances, and utility arch wires to go around compliance issues which are common with removables.
Okay, I'm not sure whether these appliances are being used in correcting crowding or for other problems that might arise in orthodontics, because if maybe we are trying to correct a skeletal problem, perhaps yes, some of these appliances that he has mentioned could be very helpful. But in situations where maybe we are just trying to correct the dental problems, we may not use them a lot.
All right. Maybe comment on the compliance issues, because I think his question has a lot to do with. He's saying he sent another one saying, sorry, meant fixed removable appliances. Could you use fixed removable appliances to go around the compliance issues? And
of course, this will need, first of all, your experience with the patient, how you are handling the patient and how he is responding to the treatment that is being given. So I guess if you are not accomplishing much, especially with the removable appliances, then maybe you would opt for the fixed permanent. Okay, but also it depends at the age of the patient and what you're trying to do. Many times I have had maybe to postpone patients' treatment or ask them. There are patients who come to me at about 8, 9 years. We try the treatment with them, but the compliance is not so good. So I just request them to come again for treatment, maybe at 12 years. I've had several cases like that actually, that the patient comes, the parent is concerned and they really want treatment, but the child is not so keen. So I have had just to, when the patient abandons the treatment, you see them coming again, maybe at around 12 years when they are now, they seem ready for the fixed therapy. Now it's much easier. And in fact, they are much more motivated and they are ready to comply now. So I guess it will depend on each individual case, how you assess and determine.
Okay. There's a comment from Dr. Salome Reri. Great presentation, Doc. Mercy Oira, Dr. Mercy Oira is asking, please recommend an ortho course for a GP while on this question.
Okay, I would not know by ortho course where exactly, because we are a global environment. So it really, currently, I think locally we may not have a lot of courses in our setup, maybe short-term courses and in whatever courses that are ongoing while we are in practice. So I think it's something that we can explore locally and be able to maybe provide courses, especially for GPs in our setup. I think that is something that we can look into.
Okay. So Dr. Tosin Sanupotri is asking, in the mandibular arch, the canine erupts before the first premolar. However, the presenter said the first primary molar is extracted to allow the first premolar, and then this is extracted. Maybe there's a clarification being sought here.
Oh, okay.
So again, I'll ask, in the mandibular arch, the canine before the first premolar. However, the presenter said the first primary molar is extracted to allow the first premolar, and then this is extracted. That first premolar is then extracted.
I think this is when I was talking about the serial extraction.
Yes, oh, yes, that's correct.
Yeah, I think it is the Nance technique where they extract the first deciduous molar. They begin by extracting the first deciduous molar, and then it's followed by the first premolar and then the canine. That was the technique. Yes, I think the reason they follow this sequence is because in the mandible, the canine usually erupts before the first premolar. So I guess to avoid a scenario where the first premolar is erupting before the canine and causing crowding, I think that is the reason why. I think the reason for extracting the deciduous molar is to accelerate the first premolar eruption, and then once it's erupted, it can be extracted to allow the canine now to erupt into that. that space. So it's just, it's very specific for the mandibular arch, this sequence.
Okay. All right, that's clear. I think, Dr. Malenya, you might have to consolidate your question, because he's asking something about Nitanium expansion appliances, but he doesn't, I don't really follow. Maybe he wants a comment on Nitanium expansion appliances. Any comment on that, Doc? Nitanium
Just
expansion?
let me look at it again. Nitanium appliances.
Yeah, expansion appliances, yes. Do you have any comment on that? Maybe this is to do with the fixed appliances that he mentioned earlier in terms of compliance.
Okay.
Yeah.
Just as a way of managing the crowding, yes, as an option.
Mm-hmm.
I think it should be possible to use them depending on the how much expansion you desire, but usually not so much. Yeah.
Okay. All right. There's an anonymous attendee. What component makes the lingual bar active? I'm more aware of the passive type.
Okay. If you look at the lingual, I believe you're talking about the lingual arch, what you call the lingual arch, yes.
Yeah.
It has a loop, a U loop. So when you manipulate the U loop, you can make it active or passive. Okay? So it depends on that U loop. That is the point of activation.
Okay. All right. Dr. Wambugu Mumenya, thank you for the presentation. My question is, after how many months does one use a transpalatal arch expander?
Okay, I'm not sure what he means by that duration, many months. I don't know, does it mean the patient's age, treatment time? So it's not so clear. And how many months? I'm not so sure what that time period is referring to.
Okay. Is there a particular recommendation in terms of timelines with the transpalatal arch? Maybe beyond what age or something?
Okay, I think, well, if it's the treatment period, for me, I usually give it between 6 to 9 months. Okay. I would expect to see some significant results at least. So I would use it for 6 to 9 months, then evaluate and make a decision whether I can continue or alter the treatment after that 6 to 9 months. At least I expect to see some change during that period. So
this is extraction? Okay, then I'll move on to the next question. This is from Dr. Dolphin Minai. How do the use of 2x4 appliances and removable orthodontic appliance differ in regard to treatment outcomes, especially in the moderate anterior crowding in mixed dentition?
I think the choice of using a 2x4 or a removable orthodontic appliance, one will first depend on the patient's your decision, because most likely you can make a decision that this patient needs a removable orthodontic or a 2x4 appliance. Okay. So depending on the teeth that are present in the mouth, okay, then you'll be able to, maybe if you have the incisors and they have erupted well, and also the molars, the sixes have erupted well and are able, maybe you're able to bond brackets or bond bands or bond tubes on those teeth, then you can and this patient maybe you feel their compliance is not good, then maybe it would guide you choosing to use the 2x4 appliance. Okay, but I want to believe that the 2x4 appliance, being a fixed appliance, would be able to give you better and maybe quicker results. It's just that maybe also considering the patient's age, it may be too much to have them having braces. Okay, like I have had 11-year-olds. You put them for them braces, and they say, no, I can't handle this. Please remove this. They come 1 week later and remove this. So again, that will influence, you know, what you're going to do, what for the patient, whether they are ready for it or not.
Okay. All right. Next question from an anonymous attendee. We've discussed the various methods of serial extractions. Any advantage of one method over the other?
Okay, I have not come across any literature that may enumerate any advantage or disadvantage, but I guess it's a matter of preference and also experience. We are free to choose whichever method you feel would work for you, and based on your experience, you would be able to see this one works well or this one will not work well.
Okay. This is from Dr. Catherine Mwonga. Thanks for the informative presentation. I work in a region where infant canine mutilation is rampant, and many 11 to 13-year-olds present with labially placed canines as a result of the premature loss of the Cs. Usually, they will present for extraction of the permanent canines and will be very resistant to any form of orthodontic treatment, probably due to finances. So my question is, can one extract the 4s in these cases and hope for the 3s to erupt into place?
Well, I can identify with what you're saying, because I have had patients coming also with similar presentations, and even not from a region where they had this canine mutilation. And I think for the timing of this is very, very important. Okay, because first you need to look at the development, the stage of root development of the 3s. Okay, and also you have to consider, is there going to be any space loss? So it's actually a gamble that you cannot guarantee that they will be able to move into that space and be able to occupy it. Okay, so it's not a guarantee, but I understand it is a challenge. It is a challenge, especially when it comes to finances. And the time period also, because it needs time. Auto treatment needs time. So many have encountered similar situations, but you cannot guarantee. It's a gamble. Yeah, especially if the root formation has already been complete and you have posterior teeth have already erupted, the 6 and the 7. The chances of you losing that space are very high if you just extract the 4s.
Okay. This is from Dr. Philip Ndungu. Where we have minimal crowding of the lower anteriors at the age between 8 to 9, and you decide to disc the B/C, is this not a temporary measure, a signal that you anticipate some level of crowding in the future? Do you share your prediction with the parent, or is it a wait and see situation? Maybe I'll repeat.
Of course, I mean, okay. Well, because we have already said it's minimal crowding, and we are deciding to disc the B and C. So we are addressing the crowding that is in there at that time. Okay, So it is not bad. If you see a sign of crowding in this dentition or at this stage, definitely would point towards crowding at a later stage. So I think it's in order to just maybe advise the patient, advise the parent, and let them also be prepared that yes, there is a possibility that this could spill over into the permanent dentition. But there are many factors that would come into play also. Depending on the amount of growth that is going to be there. Okay, yeah. So it's not bad to also warn the patient. Yes.
Okay. This is from Anupotri. How do you manage the eruption of mandibular canine, bearing in mind that it erupts before the first premolar in serial extraction cases?
Of mandibular canine?
There's how do you manage the eruption of mandibular canine, bearing in that it erupts first before the first premolar in serial extraction cases?
I think this is, if we have addressed this, it's similar to what was being asked about extracting the deciduous molar to allow the first premolar to erupt, and then now you can extract it so that the canine can come into that space.
Right. This is from Dr. Rishabh Kapoor. How decide which percentile of Moyer's mixed dentition analysis prediction tables should be used, and how do we decide, especially in the Indian population?
Okay, I know when you look at Moyer's table, I think there are different values. They're like in statistics, what they give the level of confidence interval. I think that's a very technical question. I may not be able to decide to know what would be correct for the Indian population. So maybe it might not be the right one to use to be able to, if you are trying to do an analysis.
Okay. All right. This is from Dr. Edward Odoyo. Is myofunctional appliances like MyoBrace a good intervention for crowding in the mixed dentition?
Well, I would want to know whether what you are hoping to achieve with the myofunctional appliance, because most of the time we want to correct skeletal discrepancies. So maybe if correcting the skeletal discrepancy is gonna reduce the crowding, then it can. But I think first of all, you need to understand why am I using this myofunctional appliance, and then now if it's going to the skeletal change that is going to bring, if it can benefit, then yeah, you can still use it.
Okay.
Well,
all right. A question from Dr. Kibosia. Great presentation, yes. Doc. You discuss treatment and intervention very well. What is your view on prevention? Because often we are tempted to extract incisors and canines to accommodate lingually erupting permanent teeth. Saying this is basically.
Yes, I'm back. Thank you, my senior, Daktari. Well, I think it's true that prevention should actually be what is key, because you realize most of these problems are occurring because a prevention aspect was missed out. Okay, so for example, the crowding that occurs because of premature loss due to caries, I guess if we focus on the preventive aspects, we'll be able to, we would have started addressing the crowding by reducing the, the premature tooth loss. Okay, so I know many times, yes, we take the easy way of extracting. What we can do immediately is just remove, like you're saying, the primary incisors and canines, so that the permanent teeth can be accommodated. But what we forget is that when we extract, we are collapsing the jaw and worsening the problem. So I think what I usually advocate is, if there is opportunity to expand before doing the extraction, then it's a much better approach that we try and expand first before we do the extraction. So at least we have tried to create a solution that is more forward or progressive.
Okay. Thank you for that. Another question from Dr. Mwakatobe. What is your opinion on using trainers and myo braces to correct crowding in mixed dentition? I think you've answered that already. That had to do with the correction of the skeletal area. We'll go back to Tosin Sanupotri. What is the role of a 2x4 fixed appliance in managing crowding in the mixed dentition stage?
Yes, I think in one of the slides I shared, there was a case where a canine had been lost on one side and the midline had shifted that side. Okay, so in such a scenario, if you want to correct the midline shift, I think a 2x4 appliance would be good, where you bond the incisors, and using coil spring, you can be able to correct the midline shift. So I think this is one situation where you can use the 2x4 in this dentition.
All right. Same person is asking, can intercanine growth of benefit in the management of crowding in the mixed dentition stage?
Well, if it's very mild, because the increase in the intercanine width, I think, is around 1 to 2 millimeters. So it's in mild cases, it could be of benefit. I think, like I said, there is what is called the transitional crowding, when the permanent incisors are erupting. Yeah, so there's that transitional crowding. There, the intercanine, increase in intercanine width would help.
Okay. Very informative from Dr. Ngugi. Very informative presentation, Doc. In cases where activation is required, like with the Schwartz appliance, comment on the activation in the clinic versus training the caregiver to do it at home.
Okay, I usually in my practice, once I give the patient the appliance, I allow them to accommodate to it, maybe for the first week, okay? And then now they come back. I usually don't give them the key for the activation when I deliver the appliance. I give them, at least they go with the appliance, accommodate with it. Then they come back a week later and I show them how to do the activation, okay? And usually, if the patient is old enough, I would encourage them to do the activation themselves. I actually demonstrate and let them, I see them do it. You see, they like the Schwartz appliance is a removable appliance. So that one, they can remove it and do it as you see, and you help them. So I think that with that it should be possible, and also I want to believe you would have assessed the patient and known he's of good age or she is of good age to be able to just do the activation themselves.
Okay. Thank you. From Dr. Kana Soni, at what age can I start taking CEFs?
Okay, it depends what you're looking for. Okay, if in your clinical evaluation you're suspecting a skeletal deficiency, even as early as 8 years, because there are children who will present at 8 years with serious skeletal discrepancies, then I think it is okay to take CEFs even at 8 years.
Okay. I think you commented on an online course saying that there are multiple, and there's another question here that other than magnification, are there other distortions in the OPG when estimating tooth size?
I think currently, if you can get a digital pantomogram, I think that would be, it has minimal distortion and it's normally very good.
Okay.
So I would encourage, if you are in a setup where they have digital, OPG is really good.
All right. So that will minimize the distortions. Dr. Noura Bakari, very nice presentation. At what age should you commence treatment with the lingual arch?
Okay, in this case, we are assuming the lingual arch mainly is to correct the crowding. And usually, yes, the lingual arch, we would like it to sit on the molars. So I think you have to clinically evaluate how much the molars are erupt to be able to sit a molar band. So I think it's difficult to say the age until I have actually clinically seen these molars. Can they comfortably sit a molar band?
Okay. All right. Dr. Soni Kana again, does the transfer in writing and rotating molars?
I wouldn't think so. A transpalatal arch for uprighting, maybe rotating, but very slight. But I think you would rather use other appliances or devices to achieve these movements. The transpalatal arch may not do much, may just be able to tip the crowns, but not to do much.
Okay. Then the last question here would be, please share your thoughts on the use of orthodontic pre-retainer appliances like T4K appliance in the management of crowding in the mixed dentition. I think there's a lot of questions on MyoBrace coming up in this crowding.
Okay, if this is MyoBrace, I'm sorry, I'm not very conversant, or I'm not a practitioner of MyoBrace, so I may not be able to give a correct opinion or response.
Right.
Yes.
We'll wind attendance. Thank you, Dr. Scott Omutimba, for that wonderful presentation and how that is more of a school of thought situation.
Thank you also for the opportunity. I have really learned a lot also from the interaction, and we look forward to more interactions. Thank you so much. I appreciate so much.
Before you go, to you for further clarification on matters orthodontics, and also there are other, of course, practitioners that you might link them to should there be need for people who are maybe specialized in myobrace, among other areas of practice that you are not in. Please remember, you can join the KAPD by paying 5,000 shillings and 4,000 shillings for students. Let us all try and endeavor to share this knowledge across the board. Thank you all for the attendees from Mexico, Canada. I think there are also members who came in from Tanzania, Uganda, Nigeria, and have had a very good reach. And there's a gratitude and congratulation messages available at the chat box. So thank you all. Even some from Saudi Arabia have been in attendance. Thank you all for attending, and we shall be having more of this, and possibly more orthodontists will share. I can see Dr. Malenya has also helped answer a question and clarify one element about the extraction of Cs in the chat box. Thank you, Dr. And we wish you all a good night and a good evening. And thank you for the active interactive presentation, Dr. And we wish to engage more. All right.
Thank you. Thank you.
All right. Thank you and good night to you all.